right. I'm going to give him a couple more seconds, but I'll start just introducing you if that's okay. Today, welcome everybody, and thanks for joining again. And it is my pleasure to introduce Professor Cynthia McEvoy. She's a professor at Pediatrics at Oregon Health, and in Portland, Oregon, Director of Maternal, Child and Research in Neonatology, a neonatologist, physician, scientist, and the research is predominantly on lung function and the lungs, and in early life and in utero. And she explained to me that this time she's going to talk about lung function and lung development, particularly in the NICU periods, and what that can do to lung growth. So, Cynthia, over to you.
Great. Thank you so much for the opportunity to speak tonight. And so today I'm going to briefly review some of the proposed mechanisms of nasal CPAP for the acute management of preterm infants. And many people on this call are very familiar with this, but
Recording
I think
in progress.
Even more interesting, I'm going to talk about some of the available data regarding the variability as to how neonatologists wean patients off CPAP, which is really largely understudied with few randomized controlled trials, and then discuss the potential benefits of CPAP and extending CPAP treatment on lung development as shown by preclinical and clinical observations, as well as by randomized controlled trials. So I have several NIH grants, but I don't have any conflicts to disclose. So today I'd like you to take home these main points. That number one, evidence supports that individuals track along a pulmonary function percentile that's established very early in life. And as we know, preterm delivery can affect the lungs of offspring across a lifetime. And then talk about available data on weaning preterm infants off CPAP, and talk about the potential benefits of extending CPAP therapy on lung development. So I also have a subtitle of my talk tonight, which is Ride for Research, because as mentioned, I'm not only a physician scientist, but I'm also an avid Peloton bike rider. And I think we all coped with the challenges of COVID in different ways. And I'm proud to say that not only did my research team and I meet all of our goals of our research that we did during COVID, and we'll talk about some of those studies tonight, but I became an avid Peloton bike rider. And we know that research is really a team sport with many layers needed for success. And similar to being part of the Peloton community, research, especially randomized controlled trials, have common themes of teamwork, communication, and motivation as we try to improve patient care and do good research to build a better breathing for a lifetime. So with that, I want to remind everyone that, like many great things, it's really hard to come up with a completely new idea. And it's always important to have knowledge of the past. And interestingly, CPAP was originally described and used back in 1911 in Germany by Dr. von Roos, who was the director of the first university women's clinic in Vienna. And he really was likely probably the first neonatal pediatrician. And he wrote about the use of CPAP in a textbook that was written in German as a means of keeping the infant lung inflated during exhalation. But at that time, it really wasn't embraced by experts and was lost to history until it was described by Dr. Gregory, who reported its use in preterm infants in 1971 and published that in the New England Journal, which led to widespread adoption. And this slide shows the first baby treated by Dr. Gregory. And at that time, there was no ET tube, but it was given by headhood. And this is that same kiddo at the age of 14. And he had eventually obtained a PhD, and he became a chair in fine arts. And this reminds us that in the early 1970s, CPAP was really used to acutely increase lung volumes and really was a large factor in the improved survival of preterm infants with respiratory distress in that era. However, as we all know, in the late 1980s, with the addition of antenatal steroids and also the important development of surfactant, intubation with mechanical ventilation really became the standard of care for several decades. And during this period, CPAP was used less as a first line of management, but more for support of preterm infants after extubation. But then in the early 2000s, the pendulum swung back again. And CPAP, again, is the standard of care for infants for the management early on to support their lung. And we know that CPAP is currently a cornerstone of NICU for the acute management of infants with respiratory distress. It provides a number of very important physiologic benefits to the preterm lung. It's non-invasive. It applies continuous descending pressure during both inhalation and exhalation. And we know that preterm newborns are predisposed to developing airway instability and edema and atelectasis, but that the principles of CPAP are to increase the functional residual capacity of the lungs and support gas exchange. It allows the preterm infant to breathe along this part of the pressure volume curve. It improves oxygenation, decreases apnea. It decreases their work of breathing and decreases lung injury, including both volute trauma and atellect trauma. So the early use of CPAP really has been very well studied to avoid iatrogenic damage to the lung, to avoid intubation, and its application after delivery is really the standard of care for even the smallest of babies. And this is a forest plot from the 2021 Cochrane review of the use of prophylactic CPAP versus assisted ventilation on the outcome of BPD diagnosed at 36 weeks. And this includes the important studies of the COIN trial, the SUPPORT trial, and also the Vermont-Oxford trial of early application of CPAP. And from these lines, it shows the risk ratio and the 95% confidence intervals with a relative risk of less than 1 favoring CPAP. So overall, we see there's a small but significant decrease in the incidence of CPAP with a risk ratio of 0.89 with significant confidence intervals. And this review also demonstrated a significant decrease in the risk of death or BPD or death. So although the initiation of CPAP has been well studied, there really remains a knowledge gap regarding how long should we keep a baby on CPAP and what is the optimal duration. And practices differ between units and, as we all know, unfortunately, oftentimes within units. And earlier studies from England and Australia and ICUs showed many different methods with regards to criteria used to determine if a patient was ready to come off CPAP. Some units used and some individuals used stability criteria, which could vary according to the specific postmenstrual age. The methods of weaning, such as increasing the time off CPAP each day versus slowly decreasing the levels of CPAP, was used. Also, some individuals or units transition from CPAP to high flow or low flow. And then there was different criteria used, such as what level of FiO2 to wean off CPAP. So again, taking a step back, the question that we started to consider is the discontinuation of CPAP a success? And oftentimes, as we all know who take care of babies, parents often push for this, the bedside nurses push for this. And sometimes we think this simplifies care because it can have adverse events. But is there really another way to think about CPAP therapy? And this is a figure from a review from Beaumont and Kirpolani of trials that studied CPAP discontinuation. And in this review, they reported that overall, there were a small number of trials with low data quality and with a lot of trial heterogeneity. And they, here on the y-axis, they show the percent of infants who failed the initial wean by study. And some studies, again, would wean off CPAP if certain stability criteria were met or at a specific postmenstrual age. And really the take-home message of their review was that time cycling of CPAP as a weaning method, where patients were taken off CPAP for longer periods of time each day, was unlikely of benefit and probably caused harm with the loss of FRC. Prolonged CPAP use overall diminished the use of supplemental oxygen. But looking at this figure, you can see that the occurrence of infants failing their wean varied from about 22% up to 70% in these clinical trials. So besides the fact that this review showed we needed more randomized controlled trials, I take away from this, like, are the babies trying to tell us something about coming off CPAP? And we did a study with one of our neonatology fellows here to see what were neonatologists in the United States doing currently in terms of how they were weaning patients off of CPAP when the infants were born at less than 32 weeks. And so we designed a web-based survey inquiring about various aspects of CPAP, and we administered it through the AAP neonatal perinatal section. And we got 857 responses back, which was about a 20% response rate. And in terms of the methods used to wean off CPAP, we found that the respondents, that 37% of the respondents would discontinue the CPAP directly to room air. About 59% would go from CPAP to high flow or low flow. And then about 5% would sprint or increase the amount of time each day that the infant was off CPAP. And then we also asked about the criteria used to wean, and about 69% used respiratory stability criteria, which was defined differently by each NICU, and 22% used a specific postmenstrual age, and about 8% used other criteria, which tended to be a combination of those. So again, taking a step back, we know that early CPAP can benefit the preterm lung by minimizing injury, but clinical and animal data seem to indicate that mechanical stretch of the lung with CPAP could provide an important benefit to stimulate lung growth. So again, in our haste to simplify management and get the infant off CPAP, have we been potentially missing the opportunity to use a potentially important therapeutic modality to stimulate both lung growth and development? And for instance, the Columbia experience here in the United States which has been a model for other units of early CPAP application and the avoidance of intubation. They also tend to use CPAP for a very long period of time. So again, in our haste to get the patients off CPAP, are we throwing the baby out with the bathwater? And really, could improved lung health be right under the baby's nose? And this is a figure of theorized lung function trajectories, which is a simplified version, but shows that in general, an individual follows along a pulmonary function percentile that's established very early in life. And if we focus here on the early part of the trajectory, if a baby's born on the red line, which is an altered trajectory of lung function. So if a baby's born preterm, which is the most common cause of altered lung development, as they increase in terms of their growth up to about 22 years of age, they may never reach their full potential as a young adult and be much more prone to develop lung disease and respiratory disease as they age. So the question is, could CPAP or extended CPAP take babies who are starting on the red line of abnormal lung development to be closer to this trajectory along the blue line, which represents infants with normal lung development? So could chronic stretch from CPAP benefit lung development? And here I list several studies that support this premise. And the first study is from Vios and Liggins, and it was done in sheep fetuses from 122 to 145 days of gestation. And in this study, the pressures were determined by the means of open-ended catheters in the trachea and the intrapleural space and amniotic cavity. And so they demonstrated that in utero, the transpulmonary pressure of the fluid-filled developing lung is about 3 to 4 centimeters of water. There's also been studies looking at CPAP at 5 centimeters of water and showing that this results in nasopharyngeal distending pressures of about 2 to 3 centimeters of water. We also have data from our primate center at the Oregon Primate Research Center showing distending pressure from CPAP that we'll talk about in a second. And while one approach to stimulate lung growth has really focused on fluid-filled lungs, mechanical distension of air-filled lungs could also increase lung growth. And we know that resection of lung tissue early in life can stimulate compensatory lung growth, and this can occur due to the increased distending pressure in the remaining lung. So all of these examples give in utero physiologic support for the hypothesis that spontaneous breathing at a constant low distending pressure, such as that provided by CPAP, really could provide mechanical similarities to the lung that it would see in the intrauterine environment that promotes lung growth and development. So we know that antenatal processes that alter mechanical forces such as congenital diaphragmatic hernias or decreased breathing movements and decreased amniotic fluid can impair lung growth and can result in pulmonary hypoplasia. We also know, in contrast, that complete congenital airway obstruction, such as by laryngeal or tracheal atresia, prevents lung fluid from leaving the trachea and can produce a large and hyperplastic lung. And one of the approaches to treating CDHs in utero in animal models has been shown that experimental occlusion of the fetal trachea increases the lung descending pressure and results in increased fetal lung growth and also stimulates capillary growth. So there's a number of preclinical and clinical studies showing the potential positive impact of CPAP on lung development. So these include studies showing that CPAP improved lung function in healthy preterm infants and in an animal model. There's also been studies showing that CPAP decreases airway reactivity, and also studies showing it promotes lung development, also showing decreased inflammatory cytokines after CPAP and increased expression of angiogenic growth factors. So we'll just talk about a couple of these studies in the next few slides. And most of these studies have been done either in tracheostomized rabbits or ferrets to study the effects of CPAP on pulmonary function. And these animals are well configured for this because they have long necks and can be tracheostomized but still stay mobile in their cages. And this is a study by Zhang et al., which was done in tracheostomized ferrets who were placed on CPAP at 6 centimeters of water, shown in black, or placed on control, shown in white. And they demonstrated at baseline there was no difference in the total lung capacity between these two groups of animals, but at the end of 1 week, the animals that were on CPAP had significantly increased total lung capacity. And at 2 weeks, this was also further increased. And they were able to demonstrate in these animals about a 40% higher total lung capacity in the animals treated with CPAP, and that this was also associated with significant increases in lung weight and lung total protein and DNA content in the CPAP animals compared to the control. But the lung recoil was the same between the CPAP and the control groups, indicating that this mechanical strain seemed to be associated with acceleration of lung growth, indicating that it was more than just lung distension, but likely actual remodeling of the lung parenchyma. And then in a separate study by Yu et al., 8-week-old rabbits were also tracheostomized and maintained either at high, a CPAP of 5 to 6, which are shown in blue, or low CPAP of 0 to 1 for 2 weeks. And then volumetric CT scans were obtained at descending pressures of 0 and 10 and 20 centimeters of water to measure lung volume and airway size, both pre and post the high versus low CPAP treatment. So there were no differences, as shown by the dotted lines, prior to treatment, but the high CPAP significantly increased the lung volume and the airway size at all the descending pressures. And these results were also shown with respect to the airway lumen size. There's also been data showing the mechanical strain imposed on lungs during breathing is an important modulator of airway responsiveness in vivo. And so this is a study following CPAP treatment for 2 weeks in which ferrets underwent bronchial challenge with increasing concentrations of acetylcholine. So the animals who were treated with high CPAP, shown here in red, had markedly lower airway reactivity compared to the animals treated with low CPAP. And this was significantly different at these 3 levels of acetylcholine treatment. So we know that infants and children who are born preterm often have increased airway reactivity and are often treated with asthma medication. So again, potentially extended CPAP and extended CPAP use very early in life to stimulate lung growth may also suppress airway reactivity in preterm infants. And I put this slide in. This is data from my colleague and co-investigator, Dr. Tepper in Indiana. in which he was doing a study to determine in healthy preterm and term infants whether DLCO, or lung diffusion capacity, shown in this row, and alveolar volume were related to the gestational age at birth and other respiratory support measures. And so to do this, they studied 88 full-term infants, and then they studied 48 preterm infants who did not have bronchopulmonary dysplasia. And if you look at these 3 rows at the end, they showed no difference in lung diffusion capacity, no difference in alveolar volume. And they also looked at the ratio of the proangiogenic to non-angiogenic circulating hematopoietic stem cells, and didn't show any difference in those measurements. But of interest, when he specifically looked at alveolar volume and lung diffusion capacity just in the healthy preterm infants, he found that there was a significant effect of whether the patients had gotten treated with CPAP in the NICU. So if the patients who were preterm without BPD had gotten treated with CPAP, they had significantly higher alveolar volume when they were studied at follow-up at about a mean of 9 months of corrected age. And they also had a significantly higher lung diffusion capacity. So this study was limited because it was small and it was cross-sectional, and it didn't have any longitudinal assessments, but this study of lung diffusion capacity was done earlier than any other study in former preterm infants, and was very thought-provoking in terms of the potential impact of CPAP. And we also have this clinical study was also supported from data that we did in a cross-sectional study at the Oregon Primate Research Center here in Portland, Oregon, where we were investigating whether the application of CPAP to moderately preterm primates could promote angiogenesis and growth in the premature lung. And this is just a picture. This is our NICU out at our primate center, where we were totally outfitted with everything we would need even in a human NICU. And we had 24/7 care. We would put PICC lines in. We would feed them breast milk. So everything was modeled after a human preterm infant. And in the study, we were hypothesizing that CPAP upregulates some of the mechanosensitive pathways to promote angiogenesis and growth in the premature lung. And you can see that we used the Hudson prongs, and we found out that just bundling these little babies was not as effective as in humans, because they have long arms for a reason, and they would pull their CPAP out. So we would have to keep them sedated during their days on CPAP. And our specific aim 1 in this study was to determine whether CPAP given to the primates at a moderately premature gestation, about 85% gestation, would improve alveolar volume and lung diffusion capacity and force expiratory flows. We also looked at lung structure and other mechanosensitive pathways, and we had a short-term model, and then we also had a longer-term model where we would re-measure these outcomes at 6 months of age in a separate cohort. And we were able to demonstrate in our short-term survivors that the CPAP treatment of the preterm primate, shown here in orange, had a significantly increased number of total alveoli compared to the sham treatment shown in gray. And we had also studied some gestational controls for comparison, which are shown in blue. And when we looked at our stereology, this also demonstrated fewer and larger alveoli in the sham animals compared to the CPAP treatment. And this paper is under revision in the European Respiratory Journal. So I took the liberty of inserting myself with some of my favorite Peloton riders. And here I am. So my Peloton name is Mac Attack Attack, because one attack isn't enough, and Mac Attack was already taken. So with that, let's go ahead and take a ride into a randomized trial. And so with some of that background in mind, and because we had a clinical consensus that supported a very consistent use and weaning of CPAP in our unit, we designed a randomized controlled trial to address the hypothesis: will premature infants who are stable on CPAP and then randomized to 2 additional weeks of CPAP versus our usual care, which was to come off of CPAP to room air. Would the infants who got the additional 2 weeks of CPAP have an increased change in FRC compared to those who were taken off of CPAP? And our inclusion criteria for this study were babies born at a gestational age of less than or equal to 32 completed weeks. They had to be treated with CPAP for at least 24 hours for respiratory distress, and they had to meet CPAP stability criteria. And this was a single center randomized controlled trial done here at Oregon Health and Science University. All of the patients were managed with bubble CPAP applied with Hudson prongs. And for this study, we did 3 measurements of functional residual capacity, or FRC. We did one at randomization, one at the completion of the 2-week study period, and then we also did one at discharge. In our pulmonary function testing, we used the nitrogen washout technique to measure the FRC, and we applied ATS and ERS acceptance criteria for the testing. Now, our CPAP stability criteria, which we used to decide if the patient was ready for randomization, are listed here. So the infants had to be on a CPAP of 5 and room air consistently. They had to have a respiratory rate of less than 60 breaths consistently without retractions, less than 3 episodes of self-resolving apnea, bradycardias, or desaturations in any hour for the previous 6 hours. They had to have an average saturation of greater than 86% for 90% of the time over the last 24 hours, not being treated with a PDA for a PDA or sepsis, and then tolerating brief periods of time off of CPAP. And these are previously published stability criteria used in other trials. We also had specific criteria for the patients failing CPAP, off CPAP, and having to be put back on. So if they had a significantly increased work of breathing with a respiratory rate of over 75 for greater than 2 hours, if they had a greater than 2 significant apneas in 1 hour for the previous 6 hours, any apnea requiring resuscitation, any oxygen requirement to maintain their saturation of over 85, or a blood gas with a pH of less than 7.2. So for this study, we stratified by gestational age, so less than 28 weeks versus greater than or equal to 28 weeks at birth, and also by twin gestation. Our data, we couldn't blind the investigators in the nursery, but the data was analyzed by a statistician who was blinded to treatment group assignment. And we used linear mixed effects regression with treatment group to time interaction and repeated measures for the change in FRC. And our sample size would determine a priority to show a 15% difference in the change in FRC. And so this slide shows our trial profile. We had 110 that were analyzed for eligibility. 75 were eligible. We randomized 50 patients with 26 assigned to room air and 24 to the 2 extra weeks of CPAP. And we ended up with 22 acceptable PFTs in the infants who were randomized to room air, and 22 who were randomized to the extended CPAP, which met our a priori sample size. And this slide shows the infant demographics in the 22 versus 22 patients. The room air group, or the off CPAP group, had a birth weight of 1222 grams versus 1405 in the extended CPAP group, which was not significant. The gestational ages were very similar between the groups. And also there was no difference in terms of the twin gestation. About 40% of the patients that were randomized were less than 28 weeks of gestation. And this slide shows our infant respiratory support prior to randomization. And there was no difference in terms of the median days on mechanical ventilation or the median days of oxygen between the 2 groups. So the characteristics and the PFTs of the randomized infants, these infants ended up being randomized at about 32 weeks of gestation. The weight at randomization was very similar between the groups at 1482 grams versus 1567. And at randomization, their lung volume, or FRC, was also very comparable, 41.5 mils versus 40.5. But we were able to demonstrate that at the end of the 2 weeks of treatment, the patients who got the 2 extra weeks of CPAP had a significantly increased change in their FRC. So it increased by 12.6 mils versus 6.4 mils in the room air group. And this persisted, this difference persisted at discharge, with the patients who got the extended CPAP still having a significantly increased change in FRC from baseline. And this shows this in a figure form with the solid lines showing the FRC changes during the randomization, the 2-week randomization period, with the blue lines showing the infants who got the 2 extra weeks of CPAP, and the red are the patients who came off. So at the time of randomization, the FRC measurements were very similar, but at the end of the 2 weeks of treatment, those who stayed on CPAP for the 2 extra weeks had a significant increase in their FRC. And then the dotted lines show the trajectory after everyone was taken off CPAP and prior to discharge. And we were excited to see that even up to discharge, the patients who had gotten the extra CPAP but had been off of it for several weeks still had a significantly increased FRC compared to the patients who had been taken off CPAP. And also of note, we also measured the passive respiratory compliance and resistance between these patients, and there was no difference between these groups. So from that, it appeared that this was more than just stretching of the lungs. So we concluded that from this first study, that stable premature infants born at less than or equal to 32 weeks and then randomized to extended CPAP when they met CPAP stability criteria have a significantly increased change in FRC versus infants who were weaned to room air, which was our usual standard of care. And of note, in this study, we showed we had no significant adverse events in the extended CPAP arm or in the discontinued CPAP arm. We did have one infant who failed the wean to room air. And there was no difference in the corrected age at full nipple feeds or at discharge between these two groups. So we were speculating at that point in time that an increased change in FRC could lead to improved respiratory health and maybe resetting the subsequent pulmonary function trajectories in these infants. But this was a small study, and we didn't perform any follow-up testing after discharge to be able to see if the increases in FRC persisted after discharge, and also to see that in addition to the lungs being bigger and having a larger FRC, did they potentially work better? And also additional trials of CPAP duration were really needed to look at not only longer term respiratory outcomes, but also neurodevelopmental outcomes and underlying mechanisms of this increased lung volume. So we were fortunate to be able to obtain funding from the NHLBI to randomize another cohort of preterm infants to begin to start to answer some of these questions. And again, we were randomizing preterm infants to extended CPAP versus discontinuation of CPAP with a specific aim, one, to establish whether the 2 additional weeks of bubble CPAP in the nursery for stable preterm infants increases alveolar volume at 6 months of age compared to the infants who had their CPAP discontinued in the nursery, which was per usual care. And our specific aim 2 was to establish whether those 2 extra weeks also increased lung diffusion capacity and forced expiratory flows at 6 months. And then we had several exploratory outcomes, including looking at respiratory morbidity and also neurodevelopmental outcomes through 12 months of age. So this gives an overview of the study, and just focusing here on the right figure. This was, again, a randomized single-blind study. So individuals who collected all of the outpatient data after discharge were completely blinded to treatment in the nursery. The statistician was also blinded to NICU treatment. It was done at OHSU, and our inclusion criteria included preterm infants born at 24 to less than or equal to 32 weeks gestation, who required at least 24 hours of bubble CPAP, delivered via Hudson prongs for clinical care. We excluded multiples over twins, but we included twins. So if both twin pairs qualified for the study, the first twin was randomized, and then the second twin was assigned to the same treatment arm. We followed the same CPAP stability criteria as shown here. And once those criteria were met, we obtained a baseline FRC in the nursery. Then we randomized the patients to either 2 weeks of extra CPAP or discontinue CPAP to room air, which was our usual care. And we monitored for AEs and SAEs during the 2 weeks of treatment. We did another FRC at the end of the 2 weeks. And then we followed up the infants for our primary outcome, which was our alveolar volume at 6 months of age, and also our measurements of lung diffusion capacity and forced expiratory flows. And we also called the parents monthly for standardized respiratory questionnaires during this time. So this is a picture of our infant physiology lab showing the equipment necessary for our 6-month PFT. And we performed alveolar volume and lung diffusion capacity with the single breath technique with an induced respiratory pause with the standard test gas. And this was done in collaboration with my co-PI, Dr. Tepper. We used chloral hydrate for sedation. And when we were doing this testing, there were about 6 individuals all around the patient. So it was a very intense measurement. And we followed ATS and ERS criteria for performance and acceptance, and our analysis was done on intention to treat. So as mentioned previously, really successful science is really a team sport with many layers of collaboration. So I always tell my team, you have to love what you do to be successful in life and also with research. If you're not struggling, you're not hustling, because these randomized controlled trials take a lot of effort. And also you have to really be disciplined and discipline over distraction to make sure you keep your cohort intact and have constant attention to your vital signs. So this shows our trial profile for our most recent randomized controlled trial. We screened 276 infants to consent 108. We enrolled and randomized 100 infants with 46 assigned to the discontinue arm and 54 assigned to the extended arm. And again, if both twins were randomized, or both twins qualified for the study, the first twin was randomized and the second was assigned to the same arm. Of the discontinued CPAP arm, we were able to get successful measurements in 46 of FRC in the nursery, and then 46 of the alveolar volume and lung diffusion capacity at 6 months of age. And in the extended arm, we got 52 measurements of FRC in the nursery and 47 measurements of alveolar volume and lung diffusion capacity. So this slide shows the maternal and delivery data. Both the groups were very comparable in terms of the maternal age, as well as race and education and maternal diagnoses, as well as the mode of delivery. About 67% in each one were delivered by C-section. The gestational age at delivery was was the same basically in the two groups at 30.2 weeks. There tended to be more twin pairs in the extended CPAP arm, and about 25% of the patients who qualified for randomization were less than 29 weeks. When we looked at our infant demographics between the two groups, very similar in terms of birth weight at about 1430 grams versus 1420. There tended to be more females in the discontinue arm. The post-menstrual age at randomization was very comparable between the two groups. Both of them were randomized at 32.4 weeks. The weights were very similar. The length at randomization was also very similar. We did have more patients in the group that were randomized to come off CPAP, having to go back on CPAP. But again, our analysis was on intention to treat. So this shows our measurements of FRC in the nursery. And at the time of randomization, they both had very comparable measurements of FRC. But at the end of the 2 weeks, the patients who were randomized to the extended CPAP had a significant increase in their FRC. And this difference was very comparable to the difference that we saw in our initial pilot study. We then when we brought our patients back for the 6-month testing at outpatient, we were able to get 93 out of 98 available infants back for testing. So we're very happy with that, which was a 95% pulmonary function completion rate. And just looking at the characteristics of those patients who completed the outpatient testing, there was no difference in birth weight or in gender or race distribution. There were more twin pairs in the extended CPAP arm, very similar in terms of their postmenstrual age at randomization in the nursery. Both groups were studied at about 7 months of corrected age. They had very similar weights at outpatient testing. And importantly, they had very similar lengths at outpatient testing. So this figure shows the results of our 6-month test, with the green bars showing the patients who had gotten the extended CPAP in the nursery, and the pink are the patients who got randomized to the discontinued CPAP. And we were able to show a significant difference here in alveolar volume. This was about a 100 mil difference in alveolar volume. And we were also very excited to show that on the right here, we show lung diffusion capacity, that those patients who got the extra CPAP in the nursery also had a significantly increased lung diffusion capacity when followed up as an outpatient. And this analysis was based on a multivariable mixed linear modeling. So we accounted for the correlation between twin pairs, also adjusted for the gestational age at birth, which was the stratification variable, and also the sex and the length at outpatient testing. We were also able to complete measurements of forced expiratory flows with the raised volume rapid thoracic compression technique in 76 infants at the outpatient testing. And again, the green bars show the extended CPAP arm, and the pink, the discontinue arm. And so we demonstrate a significantly increased or improved forced expiratory flow also in the infants who had gotten the additional CPAP in the NICU. So the FEF 50 was higher, the 2570, FEF 2575 was higher, the FEF 75, and also the FEV 0.5. So again, speaking to decreased airway reactivity in these patients. We also had mentioned, as mentioned, we had administered a monthly standardized respiratory questionnaire between the two groups. And so we had a median number of RQs in each group of 12. And when we looked at the occurrence of wheeze, 44% of the patients in the extended arm reported an occurrence of wheeze versus about 56.5% in the discontinue arm. So that had an unadjusted and an adjusted p-value of 0.19. So it didn't reach significance, but was going in the right direction. And really, we weren't powered for this clinical outcome. There was a significantly less healthcare provider diagnosis of wheezy bronchitis between the two groups, about 2% in the extended CPAP versus 13% in the discontinued CPAP. So in conclusion, from this study, we concluded that stable preterm infants randomized to extended CPAP versus discontinued CPAP in the nursery have a significantly increased alveolar volume and lung diffusion capacity at about 6 months of age. And since premature infants have impaired alveolarization and vascularization, an increase in alveolar volume and DLCO due to extended CPAP may improve respiratory health and may improve lung function trajectory. We also have a number of sub-studies that went on through this project, and just to talk about one of them, this is actually a figure from Dr. Carlo's group in Birmingham, looking at whether extending CPAP compared to weaning preterm babies off CPAP to low flow reduces intermittent hypoxic episodes and respiratory instability in preterm infants who had met the criteria to discontinue CPAP. So they randomized 36 infants less than 34 weeks of gestation who had been on CPAP of 5 and less than 30% and meeting respiratory stability criteria to either continue on CPAP for 24 more hours or wean to low flow at 0.5 liters to 1 liter. And they looked at episodes of intermittent hypoxemia. And so they were able to demonstrate that the patients who were randomized to the longer period of CPAP had significantly decreased episodes of intermittent hypoxemia during this period of time. And we were also interested in this. So this is a slide of a sub-study done by one of our neonatology fellows from this our recently completed study, looking at episodes of intermittent hypoxia around oral gastric feeds in the preterm infants, and also looking at the effect of CPAP on these episodes. And she was able to demonstrate post-feeding, looking at the patients who had been randomized to extended CPAP versus discontinued CPAP, that there were significantly less episodes of intermittent hypoxemia to less than 90% after feeds. And when she looked at these episodes during feeds, there was no difference. And when she looked at during and post, and just the patients who were on room air, there was no difference in these episodes of intermittent hypoxemia. And she also looked at the total number of episodes of intermittent hypoxemia for the 14 days of the randomization period. So the patients who were randomized to come off CPAP had 1,373 total episodes of intermittent hypoxemia to less than 90%, versus 769 in the patients who were randomized to the extended arm. So again, pretty striking differences. And we picked this interval because the prevent study had shown that these episodes correlated with subsequent neurodevelopmental abnormalities at follow-up. So as in closing, I wanted to just go back and review a couple of other interesting facts and observations from our CPAP study at the Oregon Primate Research Center. So as part of this study, as part of the study validation, we had placed an esophageal microtransducer in the lower 1/3 of the esophagus so we could measure pressure being transmitted to the lungs in the babies who were on CPAP, and then also show that the babies who were on sham CPAP were not getting any transpulmonary pressure. So here you can see the esophageal microtransducer, and here's a PICC line in this little baby primate. And so when we had the patients on CPAP and had placed this esophageal monitor and measured the transpulmonary pressure, when we had the primates on 0 centimeters of CPAP, this was the tracing. When we increased the CPAP up to 3, you can see an increase in the transpulmonary pressure. When we went up to 5, you could see an increase in the transpulmonary pressure, so pressure being transmitted to the lungs. And then when we went up to 8, again, there was an increase. But when we had patients on the sham CPAP with just flow but no CPAP and measured their transpulmonary pressure, when the flow was 0, here was the tracing. When we increased the flow to 3, we saw no difference or no increase in our transpulmonary pressure. Flow of 5, no change, and also flow of 7. So again, this was important for the validation of our primate study, but also shows that without CPAP, just increasing the flow does not increase transpulmonary pressure or transmit pressure to descend the lungs. So with that, I'll just take some questions, and I have a lot of people to thank, and mostly the families who were willing to participate in this study and come back for our great follow-up. So thank you.
Thank you, Cynthia. This is a great overview, and to be honest, I really have to commend you and your team of investigating thoroughly this question we have every day when we do our rounds in the NICU. When should we stop our CPAP? You took us to some great things: CPAP physiology, what is behind lung growth, how to measure these kind of changes and the limitations in that. And then you showed your studies where you could show that if you do prolonged periods of CPAP, at 32 weeks that it actually increases your lung capacity with, well, sort of some evidence already growing now that it's persisted at least in young infancy and hopefully into adulthood. And I'm assuming you're going to go that way in time as well, which is with a lot of our studies where we get our limitations of, well, either funding and time. You know, who's going to, you're going to hand over the stick to the adult physicians to do this kind of work. And there's a couple of questions in there, which we're going to go to. The first is from Sam. Sam, I don't understand your question. Could you ask your questions, please?
Okay, yeah. Hi, hello.
Hi.
I am Sam, neonatologist from Singapore.
Oh, great.
Thank you for your excellent talk. My question is, what would be the optimal CPAP when you extubate the baby in the first 3 or 4 days for extremely preterm infants below 800 grams?
Great question. We didn't really study that in this study, but I think that's a great question. It'd be great to have a transpulmonary pressure manometer in some of these patients so we can see how much CPAP was really being distributed to the lungs. I know there's quite a bit of variability. We asked a similar question in our survey that we administered as to how high neonatologists would go up on their CPAP. Some would go up as high as 8, depending on what the FiO2 requirement was. So I think there's still quite a bit of variability. I think you have to balance the CPAP delivered with how much FiO2 the premature patient is on. But without measuring without measuring the transpulmonary pressure, I think it's hard to just give a blanket answer.
Right. Can I ask you, many units are now using the high flow nasal cannula oxygen.
Mm-hmm.
Very often, there's a sort of, the importance is many say, okay, nasal injury can be prevented. Nurses like it, and also the parents like it. The advantages which you mentioned, using the nasal prong CPAP, do they occur when you use prolonged high flow nasal cannula, oxygen or air?
I mean, from our study, prolonging the use of CPAP has the benefit similar to the distension that the lungs would be seeing in utero of distending the lungs and promoting lung growth, as well as probably capillary growth, is what we showed at our 6-month follow-up. So I think, we have to take careful consideration. We didn't look at high flow versus CPAP in this study, but from the 2 slides I showed at the end, at least from our primate data, with CPAP, we were able to show increase in transpulmonary pressure. With the high flow, we didn't show any increases in the transpulmonary pressure. So from our data, high flow is probably doing something to stent the upper airway and to redistribute the PCO2, but from our primate data, it's not distending the lungs, which is the premise of increased lung growth and capillary growth, distending the mechanical distension from CPAP. So we didn't have any adverse events from our extended CPAP study. And again, I'm a clinical neonatologist too, so I know there's pressures from the bedside nurses and also from the families to be able to see baby's face and to maybe make the care simpler to do. But I think we have to think about the potential benefit of the mechanical distension from CPAP to promote lung growth and development, because all of our preterm infants are on an abnormal pulmonary function trajectory. And this could be just extending CPAP could be a simple way to improve their longer term pulmonary function outcomes.
Yeah,
thank you very much. Yeah.
If that lasts for a lifetime, we really need to reconsider what it is we're doing and what it is we're treating. There's a question here about subgroups, SDA, or what about your groups are rather big? I call them rather big, but what about the very, very tiny ones? Can you comment on growth restriction or very tiny ones?
Great question. We excluded patients who were less than the 3rd percentile, so we didn't have any very SGA patients. We had projected that about 50% of our patients would be less than 28 weeks, but as the study progressed, only about 25 to 26% of our patients were the very small patients. So I think a larger trial would need to be done to look more specifically at the smaller patients. But as we all know, all preterm babies have altered lung development. And although a lot of the focus has been on the very preterm infants, 30 weekers, 31 weekers, 32 weekers, they have altered lung development and abnormal pulmonary function and increased respiratory morbidity as they age. So I think that we need to take that into consideration as we're looking at how we're using CPAP.
Yeah, that makes sense. Brett, you want to ask some questions in your comments? You want to explain?
Thanks, Kurt. Yeah, hi Cindy, how are you going? Thanks for
Hey, good. How are
a great
you?
talk. Thank you. I get you were just sort of saying that you've enrolled a relatively well population of babies compared to some. So I'm interested to know where to next with this. You know, we really need to know about the extremely preterm babies, the ones that aren't in air and they're at 32 weeks. You know, we've got a lot of babies in our NICU here that are in oxygen and still on relatively high CPAPs at 32 weeks. So I'm interested firstly whether you saw any shorter term clinical differences in things like BPD, home oxygen, time on support, etc. in the study you've done, and then whether you have any plans to really go up a scale with enrolling lots of smaller babies and at a bigger scale.
Yeah, that's a great question. Our study was small to answer the question about bronchopulmonary dysplasia, but we looked at that. So the duration of oxygen, there was no difference in the duration of oxygen. There was no difference in the occurrence of BPD between the two groups. And as we all know, BPD is so complicated. The way we diagnose it is the way we treat it, and it's so multidimensional in terms of not only lung parenchymal issues, but also upper airway issues, control of breathing issues. So I think a larger study with more smaller babies, looking at reevaluating potentially the criteria for when you would randomize patients to CPAP versus coming off CPAP, or CPAP versus high flow. I know that as the last person had asked, high flow is popular, but we didn't study that in our study, because our clinical consensus here at OHSU was just to take the patients off CPAP and go to room air. And from our primate data, it doesn't appear that we get lung distension from a high flow nasal cannula, but we didn't specifically look at that. So I think a larger study with more smaller babies is definitely needed.
So can I ask you a question about these prolonged CPAP at the phase where these babies wanting to do some suck feeds? What do you do with suck feeds on CPAP?
Great question. So since we randomized most of our patients at 32 weeks, so they would come off around 34, even to 35 weeks. Most of them, I would say all of them, were really not showing nippling cues. Currently, we're not nippling patients on CPAP, but I don't think that's been well studied up to this point yet.
There's one more question in the box about, you did 2 weeks extra. What about 4 weeks extra or 6?
Great question. We base our study on that seminal study by Zhang et al., where he showed the 2 weeks of CPAP really significantly increased the total lung capacity. But again, I think that's still an open question. What the duration should be, potentially also what the level of CPAP should be that is getting transmitted to the lungs.
Yeah, now look, I think what you do, so next to the clinical study in your primate studies to make sure, what pressure is actually arriving. There's very old studies which already showed it, but I think it's good to repeat it in this population at this time. And you showed it again, that no, the pulmonary pressure is only being achieved with PEEP and not with flow. I think that's really good. I think we getting at the end. It's almost 2 o'clock and it's getting late for you. And look, thank you so much for presenting for us. This was a great overview, and I can't thank you enough for keep on studying this, because we really would like some more answers in this everyday question.
Great. Well, thank you so much for having me.
All right. Well, thanks everybody for attending. Next week we will be back. We're going to have Marty Fisher from Cincinnati talking about preterm skin and skin development, which is always interesting as well, which will start 1 hour earlier. All right. Thank you, everybody.
Bye.
And thanks for attending.